All right, everybody, welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Cedar Therapeutics. It is Thursday. It is that time. Welcome back. If you are new here, say hello in the chat box in the comment section. Let us know where you're signing on from, wherever you are in the world. And if you're a regular, you're probably already doing that. And if you're excited about today's episode, hit me with a yes in the comments. Let me know you're here and you're ready. We are ready, as we always are, and it looks like the numbers are starting to come in, which I love to see. If you're not familiar with me, my name is Rain Bennett. I'm a filmmaker that's been working with CCF for a decade, folks. That is 10 years, believe it or not. I started when I was living in New York, 2011, creating video series, and we've continued to push that pursuit to help spread awareness and educate people through video on neuroendocrine tumors. And we had started doing Facebook Lives, and then when the pandemic hit, we really pivoted, even though that word is overused, I think, these days, and started doing this show every week. We've been doing it just over a year now, and man, it's been such a great part of my career and my life, and I hear that sentiment echoed every week from you all at home, how important the show is to you. And that just, it makes us all feel so good and feel like we're doing a good job here. So, go ahead and let us know where you are signing on from. Before we get started, we always want to thank our sponsor, Cedar Therapeutics. We absolutely couldn't do the show without their support. And we always have this disclaimer at the top of the program, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience at home, have not been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that last line is really the takeaway. Hey, we're going to give you some good advice, hopefully answer some of your questions, but by no means do we or our guest know your specific case. So take that advice and some of those answers to your question back to your home team, which does, and make the best choices for you moving forward. As you all know, as we reiterate every week, each case is different with this disease, and therefore each journey forward is as well. So I'm really excited about today's guest, Dr. Andrew Hendifar. How are you, Dr. Hendifar?
Hi, good to be here, Rain.
Yeah, thanks for joining.
I can't believe you've been doing this for 10 years. That's incredible.
Yeah, well, not in this show, but we've been doing different kinds of video to achieve the same purpose. You know, we in 2018 we did an award-winning patient-centric series. We've done a lot of treatment-based videos, and we've just covered so much ground. And I really have to give a lot of credit to CCF for having the foresight to see how prominent video would be in education, in society and culture these days. And so they really were ahead of the curve in doing that. And I think this show is too. I think they're continuing to push that envelope, being able to reach as many people as we do. So for those that are tuning in, Dr. Hendifar, who might not know you, might not be familiar with your work, tell us a little bit about yourself, and and just in terms of where you work, what you do, and as I like to put it, the role you fill in the neuroendocrine tumor world or community.
Yeah, happy to do that. So I'm a medical oncologist, and I have a specialty in gastrointestinal malignancies. And I've been doing that for close to 15 years. And along the way, one of my mentors was Edward Wolin, who took me under his wing, and he taught me all I know about neuroendocrine tumors. And so, in Los Angeles, I help lead the multidisciplinary neuroendocrine tumor service at Cedars Sinai Medical Center. And basically my job is to, help patients with neuroendocrine tumor diseases, guide them in the right direction. I don't really do any surgery. I don't do much, but I do help as much as I can. Sometimes I'm the quarterback, and I like to joke, sometimes I'm just the water boy, I'm just there to help out. And I think the most important thing that I really do, though, is I bring everyone together at our hospital once a week.
Yeah.
And we have a tumor board. And on my team, my nurses, my nurse practitioners, they really help so much organize that meeting, make sure we present all the new patients, all the cases that have a management change. And I think that's where I really help the most in the community, is that I'm able to any neuroendocrine tumor patient, I'm able to present them to a big group of different types of doctors. They can review the case and they can come back. Sometimes we don't always agree 100% on what to do, but it's usually a great way to make decisions for our patients. Yeah.
I have a feeling we're going to talk about that a little bit more. We always tend to, and it sounds like the way you described your job in my world would be like what a producer does, which kind of is we wear a lot of hats, and you're kind of the gel that keeps everybody together. It sounds like. So the way you explained that reminded me of that. People are signing on. Florian says hi from Germany. Congrats to your son, Rain. Thanks so much. He is 1 month old yesterday. So we are in the thick of it, folks. Not a lot of sleep, maybe 4 hours last night, but hey, I'm here for you. That's what I'm here for. Looks like everybody is excited about today's show. Hello from Elon NC. Hey, North Carolina in the house. I love to see that. That's not too far from me. I'm in Durham, right near Duke. So folks, go ahead and start sending in your questions. You know that we get a lot. The numbers are already looking great for today's show, which says a lot about our guest. You know that we probably won't get to all the questions. So I just want to go ahead and let you know, and I will remind you throughout the show that if we don't get to it, or if you have a follow-up question, I urge you to reach out to CCF either here on the Facebook page. You can send them a private message, or at their website, carcinoid.org. Promise you they will get you the information that you need, or the person or people who will give you the information that you need. You can always rewatch this show as soon as the show is done. It's going to be posted on Facebook and will live evergreen on the videos tab. So you can always access it, or someone else can access it. And starting Monday, we republish it to YouTube for those who do not have Facebook, although we have a huge community of over 20,000 people here on our Facebook page. So we reach a lot of people that way. So there's two things I always ask from you to help me do my job better, which is to serve you. So you're helping yourself here. One, the biggest benefit I think from this is the information and of course the community that we cultivate here in the show, but it's really that interactive session that we have, the virtual interactive session we have with our guests, with our specialists, with our experts, right? So I think being here and being able to ask a question is really going to be the most value. Of course, you can watch the show back and learn a lot, but if you have a question that's been giving you some trouble and your team's some trouble, this is what's going to help people. So we want to get as many people here as possible. If you know somebody that would benefit from the show, tag them in the comments. You can actually share the video to their page. Let them know that this is going on. Every week we see that our numbers as the hour goes on increases, and that's what we love to see. And secondly, if you see questions in the comment box that you also have, that you're also interested in learning the answer to, you can like it, love it. Any of the reactions that Facebook gives you the option to, they all operate the same way as far as I'm concerned, which is to effectively upvote it. It lets me know there's a demand for that question. So as I'm combing through hundreds of questions, when I see 7 people had this one, I'm going to make sure that I deliver it to Dr. Hendifar. So that's my ask of you. You all do a great job of it. It helps me out a lot. Finally, before we get started, have you downloaded CCF's free Net Cancer Health Storylines app? This app is really good. It's very functional. It makes it very easy to record your symptoms, your mood, your nutritional concerns, medications, all of that. So if you haven't checked that out, do so. We will put a link to that in the comments. And to that point, if there's anything Dr. Hendifar references today, a medication, a blog, or any resource, we'll do our best to go ahead and get that in the comment section too, the link to that, so that you don't have to pop out, open a Google Chrome browser window and search for something while you're listening to the show. We want to keep you here and keep you focused, so we will do that work for you. All right, let's get into the show, folks. Send in those questions for me. Dr. Hendifar.
Yes, sir.
First of all, what a great mentor with Dr. Wall. Like, what a beast in the net community. I mean, we've done a lot of work with him, but wow. I mean, how long did you kind of study under him or work with him?
I worked with him for several years, maybe 3 or 4 years.
Can you put your finger on like some of the biggest lessons learned in this specific, disease, this specific community, working with someone of that caliber?
I think the one thing that I learned from, first of all, he's brilliant.
Indeed.
He knows everything there is to know about neuroendocrine tumors. And he helped me kind of not only treat GI neuroendocrine tumors, but also lung neuroendocrine tumors, because we would also get involved in those diseases. I think what really is impressive about Dr. Wolin is that he does not quit ever. He
Seriously.
does not stop. He is nonstop. I don't know if he's ever told you about his stories running the LA Marathon on a whim, but
That's
he's something
wild.
special.
I don't think I've heard that, but he is
I
a
miss him a
character.
lot. I miss him a lot.
Yeah,
I
he's
know he's in
quite.
New York now. He's doing great, but we miss him out here.
I bet. I bet. I have a patient of his and yours. Carol says, "Hi, Dr. Hendifar. I was your patient after Dr. Wolin left for 3 years. So good to see you again. I always love when patients join us for the show." Um, so we got some questions coming in, but I wanted to go ahead and set the tone since you brought it up, talking about the multidisciplinary team. This is something, Dr. Hendifar, that comes up every week. We're really starting to understand the importance of that. In fact, we've created a video in one of our series last year, I believe, on multidisciplinary teams and the importance
Right.
of that. Let's lay some groundwork there for those who may be new to this journey, to why specifically for NETs a multidisciplinary approach is so vital.
It's incredibly vital because the disease is so multidimensional
Mm-hmm.
that there are different ways to view it and different ways to treat it. And there are different aspects of the disease. So most of the time, there are very few practitioners who will be able to, understand all the dimensions of the disease fully. And having expertise in different areas all come together really helps everybody a lot. So I can give a brief example. If I have a patient who has a few liver lesions with a neuroendocrine tumor, the number of treatments that will be available to that patient are so many. I mean, we're
Right.
talking about oral pills, SSA injections, PRT, liver-directed therapy, surgery, but there are nuances to try to select what's the best one for that patient.
Mm-hmm.
Maybe it's the comorbidities of the patient. They have bad diabetes, they have other issues. Maybe it's where the location of the tumor was. Maybe it's right on the outside of the liver, so it's really easy to remove. It's like a chip shot, the surgeon likes to say, right? Or maybe they already had a surgery which makes liver-directed therapy dangerous and not a good option.
Mm-hmm.
So instead of taking our poor patient and having them see 6 different specialists and go kind of around in a circle to try to figure it out, we're all there one time, one place. We go through everything, and it's just rapid fire, back and forth, boom, boom, boom. All the people come together. And like I said, it's not a situation where we're always going to pick a unanimous decision of what
Right.
the thing is, and that you don't need that, but at least you can get all the different viewpoints and perspectives, and we can send that back to the patient. So it's great for these types of diseases. It's really wonderful. I was first exposed to one of the great tumor boards when I was a fellow. I was at UCLA, and I was able to be at the sarcoma tumor board, and it was one of these for a tumor board aficionado, one of the first tumor boards. It's one of the greatest tumor boards ever. And I got to learn. It's really a special thing to see it done well.
Yeah.
And although we haven't quite reached that excellence, we're getting there slowly. So it's one of my favorite parts of the week, I gotta say.
I can see. I love how excited you get about it. Like, it's the greatest tumor board. That's so awesome. But that's, I think it's a lovely quality, but I don't think it's unique to you. Like, people are passionate about this disease that work in it. That's what I love about the experts that we have on the show, is like, nobody is like, just kind of like apathetic, like they just landed here. Everybody's here almost by choice. Like, they really enjoy working with this disease, maybe the challenges it presents, and I think the community as well. But I just love how you lit up there. You may have said this in your intro, but how often does your tumor board meet?
Once a week.
Once a week. Yeah.
But not every. I mean, occasionally we have Monday's a holiday day.
Yeah,
So
yeah, for sure. Now, you also had mentioned kind of, in passing, like nurse practitioners, nurses that are a part of that. I know that the multidisciplinary teams that we've worked with and talked to kind of vary in terms of the people that meet at that table at the tumor board. So who's at yours? Like, who's at that table?
So we have medical oncology. So we have GI net specialists and lung net specialists, and any GI oncologist in the community. And this is another point about it. It's an open conference to any physician in our larger, cancer network.
Gotcha.
So anybody who's got a Zoom or a telephone, they just hook up and they can present their case, as long as they give us the information beforehand and we can review it and put it together in a presentation. So then we also have support staff, right? Nurses and nurse practitioners. We have surgical oncologists.
Sure.
Now, those are hepatobiliary surgeons who are the ones who do pancreas, liver. And then we have tumor surgeons who do more of the cytoreduction, the bowel stuff. Sometimes we'll have a lung surgeon. We have endocrinologists. And so an endocrinologist, of course, is a specialist in different areas. Our endocrinologists help with the diabetes, but they also help manage adrenal tumors, especially functional, like pheochromocytomas. Those can be tough. Sometimes they help us with the insulinomas as well. We have gastroenterologists who attend. We have pathology. Pathology is a cornerstone of the conference. So we review all the path in the cases. And then radiology. And radiology now is two radiologists. One is a normal, radiologist who reads CTs and MRIs. And then we have a nuclear medicine physician who, because of PRTs become so important, they're really clued in. They're showing the gallium scans, and they take an active role in discussing whether or not a candidate is for PRT. And then the other, I think, major component is interventional radiology, the ones who do the liver-directed therapy. That's a big part of our program here. Dr. Wola made it that way. So we always have interventional radiology on board to discuss those options as well.
Got it. Thank you so much. Well, listen, the questions are pouring in fast, so I'm going to go ahead and start taking some from the audience because that is what we're here to do. And I'll go ahead and tell you they're good questions.
All right.
Let's start off. Skip, who is a top fan. What's up, Skip? Skip says, "Why are mesenteric tumors so difficult to remove?"
That's a great question. So the mesenteric tumors can be surrounding the mesenteric vessels. And those vessels include an artery and vein. And it's very difficult to remove tumors that are wrapped around those vessels. Now, sometimes if the tumor is just touching them and the surgeon is very expert, they can try to peel it off, but that's tricky. Definitely, I rarely see anybody with a mesenteric neuroendocrine tumor removing the tumor, cutting the vessels, and reconstructing them. That's just way too out there for this disease. So usually, and it's an unfortunate circumstance when we have patients with tumors around the mesenteric vessels that are unresectable. It's a little bit of a difficult situation, and we kind of resort to other therapies that we could use to help the patient, but surgery tends to be not done.
Gotcha. And speaking of surgery, shout out to Dr. Alexandra Ganji, who has been on the show before, who is also at Cedars Sinai with Dr.
She's always attending our board.
Yeah. She's awesome. She's been on the show, and we did a surgery video that she was a part of as well. So thanks, Skip. Hopefully that helped. Next question from Jan. Jan said, "I would like to learn about a net found on the ovary. I know that's not really a normal place for it to begin. Is that something that you've seen before, or is there anything unique about that?"
Yeah, so you can have it's very complex. So you can have two situations. You could have a neuroendocrine tumor that spreads to the ovary, or you can have a primary ovarian neuroendocrine tumor. And there's several different types of neuroendocrine tumors that can arise from the ovary. All of them are exceedingly rare. But typically the ones that arise from the ovary, the prognosis is pretty good. Okay. So definitely I would, see a local net specialist and have the tissue from the ovary reviewed carefully. If you do like a gallium scan, you can see if there are any other areas of involvement. And you can go from there. But I have seen a lot of ovarian tumors, primary ovarian. They have very fancy names that you'll see that are named after different doctors. I don't think that's going to be so helpful, but for the most part, they tend to be quite benign. I mean, I've seen them as a component of a teratoma. There are these, Breslin-Bruner tumors. They're all different types of rare entities. But like I said, if it's from the ovary, typically that's not as tough as other situations.
Okay, good to hear. Thanks, Jan, for your question. Hopefully that helped. Next question from our friend in Germany, Florian. Oh, by the way, Florian, what city are you in? I've got some close friends in from Hamburg, but in Berlin. Florian says, if a tumor is present and it does not light up on the gallium-68 dotatate PET, does that mean there are no somatostatin receptors, or can there be other reasons as well why that wouldn't light up?
Yeah, that's a really good question. I would say it probably would have to do with what scenario you're in. Most well-differentiated neuroendocrine tumors should have uptake and you should see them on a gallium scan. Sometimes lungs that are well differentiated, lung neuroendocrine tumors won't. And sometimes it has very little uptake. And sometimes different lesions have different amounts of uptake.
Mm-hmm.
So it really depends on the scenario that you're talking about. Are there any other reasons? You can always check the quality of the scan by referencing the liver and the spleen and the pituitary. So there's certain, areas of a gallium scan that you can look at and say, okay, well, we know that there's uptake, these are like these reference organs that get uptake. So you can tell the quality. The quality of the scan should be able to be assessed by nuclear medicine people, physicians. And if they say the scan quality is good, then there's really no other reason to think that they won't have uptake.
Got it. Thanks, Florian. Hopefully that helped. Next question from Shane. If the primary pancreas NET came back with a Ki-67 of 1% after surgical resection, will the liver Mets also be at 1% or close by, or might there be a large jump in Ki-67? And if we could, let's identify what Ki-67 is.
Right. So Ki-67 is a proliferative index, and it goes from 1 to 100. Mm-hmm. So if you have a 1% proliferative index in the pancreas, that's great. That means it's a low proliferative rate. I mean, to me, it means that your tumor is a grade 1 tumor. You could have liver tumors with a grading that's a little bit higher or the same. Any of those possibilities could occur. But what the meaning of all that is, it's hard to say. But generally speaking, if your primary tumor is resected and the Ki-67 is 1%, that's good, and it's a low index. And I think you're dealing with the well-differentiated grade 1 tumor. And again, liver tumors from different primaries, you usually expect a little bit of an increase in the Ki-67. But what exactly that means, it's really unclear, and I don't think it means that much.
Got it. Thank you. Folks, if you're just joining us or joined us late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Cedar Therapeutics. Today, we are here with our guest, Dr. Andrew Hendifar from Cedars Sinai. Go ahead and send in your questions. We're going to keep plugging along. Dr. Hendifar, Jean says, I'm a stage 4, grade 3 NETs. Primary was in the SI. I've been on Afinitor for 8 months, and suddenly, after doing well for 7.5 months, I have very extreme fatigue and diarrhea. Common, or is it possible it has stopped working? And I've done surgery, PRRT, and radioembolization already.
Yeah, I mean, that's sorry to hear that you're not feeling so great. Fatigue and diarrhea, it could be, either from if you have carcinoid syndrome, I'm not sure, but if you have carcinoid syndrome, it could represent that things are getting a little bit worse or less controlled. But you can get diarrhea from everolimus as well, or Afinitor. So, you should also check to make sure that it's not an adverse reaction to the medication.
Darina says, would you suggest a patient to be on lanreotide for preventative purposes after a surgery that may remove all the visible nets in the abdomen peritoneum? Primary is in the appendix with mets to the peritoneum, by the way.
That's a great question, and something that we debate.
Oh, okay.
I think there are two ways to approach a problem like that. Usually when we have the, multidisciplinary meetings where I talk to my surgical colleagues, they're like, can you do something, please? And then I'm like, well, technically you're supposed to have visible disease to measure when you're giving a therapy. Because as a medical oncologist, that's one of the things that we do is that we don't like to give treatment without something that we can see, because then we don't really know if it's helping or not. Mm-hmm. So it's a debate, sometimes you're practical, sometimes you're more idealistic. But after this discussion, I think, either option is very reasonable. It's reasonable to go ahead and treat with the SSA. Mm-hmm. It's also reasonable to wait until you see something grow on a scan and then start the SSA. So the different schools of thought, nobody knows who's right or wrong. And I don't think there's a right or wrong answer. There's just the best answer for you. And that would be, a decision based between the discussion with you and your providers. Yeah.
Absolutely. And Dorina, that takes us back to my initial point, that little disclaimer in the beginning. Hopefully that helped give you a little guidance there, but definitely take it back to your home team, to your medical advisors. Oh, next question from Eva. Eva says, I know someone with a non-functional PNET with liver mets, and her doctor has her on somatostatin monthly shots. How can that help if she has no receptors?
Right. Well, yeah. If the tumors have no receptors, then you're right. Then that's probably not an ideal treatment.
Okay.
But sometimes people use functional in different ways. So sometimes people use functional to describe the existence of somatostatin receptors, and sometimes people use functional to say that there's a syndrome, like an insulinoma or
Right.
glucokinoma. So if someone's telling you it's not functional, maybe just make sure that they're saying that there's no somatostatin receptors on the gallium.
Got it. Next question from David. Question is, MDT meetings, multidisciplinary team meetings, are great and generally a one-stop shop. What are your thoughts on selective internal radiation therapy, SIRT, and patients' response to this treatment following PRRT? That makes sense?
I hope I'm going to answer this. So they're asking about localized radiotherapy after PRRT. Got it. Yeah, I think I understood the question. So,
okay.
There's always a question once we start using radiation is how much radiation the liver can handle. And it's a great question. We know if we use one modality, how much radiation, if we use radiation, we know how much the liver can handle, how many gray, the radiation toxin gray. If we use Y90, they also know how much radiation. And if we use PRRT, we have an idea. But when you start mixing and matching, then it gets a little bit complicated. Okay. So there's no real, no one knows for sure what the right answer is. But I would say typically SIRT is very well tolerated. And PRRT doesn't deliver as much radiation to the liver as something as Y90. So generally speaking, it seems like reasonable and okay to me. Okay. But again, you got to get into the nitty gritty with your local team about that. That's something that requires thought and deliberation.
Absolutely. This is an interesting question. If one gets pregnant while living with a NET, does it make the pregnancy high risk? And would it matter if the OBGYN is familiar with NETs? How would you go about, or how would you go about finding a specialist for this? Would you need a specialist for this? So does it complicate pregnancy in any way?
Yeah, I would say that if you are pregnant with a neuroendocrine tumor, it would be high risk. You would have a lot of considerations. It's not something that I've dealt with actively, but I think you'd have to be really conscious of any therapy that you use. You have to really consider that with your local team, with the high-risk OB-GYN. I don't know many OB-GYNs that specialize in NETs, so I think what you'd have to do is you get a high-risk OB-GYN, and then you team up with your local NET doctor, and you start those discussions. And it'll also depend on if you have active disease. If you're in remission, then it's probably not as high risk as if you have active disease. But in both circumstances, I would recommend seeing a high-risk OB.
I mean, this is one of those situations where the multidisciplinary approach is
and you could find you could find some expertise too, maybe even nationally or internationally. But call Dr. Wolin.
Exactly. Erica says if a primary esophageal tumor is not removed but rather monitored, can it continue to metastasize while on monthly lanreotide shots?
Right. I mean, this is a good question. So any tumor that's well differentiated can be controlled by somatostatin analog therapy, but the tumors will still grow eventually. So the answer is yes, it can stop it from spreading, and yes, it can spread. So both are possibilities. Usually what happens is for a while, it will stop it from spreading, and then eventually it will have. How long that takes, that's what we don't ever know. But if you have a well-differentiated tumor and it does spread a little bit, it's not something to be overly, not overly, I mean, it's concerning, but it's something that I think would not be unexpected and would not be something that you couldn't handle. if it's a well-differentiated low-grade tumor.
Got it.
So unlike other cancers, I got to say, so, like if you had an esophageal adenocarcinoma, it would really be a difficult situation if it spread. But fortunately for neuroendocrine tumors that are low grade, and I'm assuming that's the case because you're on the treatment for a low grade tumor, it's not kind of the same situation if your tumor spreads to a different organ.
Got it. All right. Hopefully that helped. And coincidentally, Dorina, who had the question about pregnant with Annette, is seeing Dr. Wolin. So
Perfect.
There you go. You're in good hands. All right. Next question. Suzanne. If a primary tumor is not found with someone who has carcinoid syndrome, could there possibly be a layer of film of carcinoid tumors that cannot be seen? Or could there still be, if a primary is not found, could...
Well, I understand the question.
Okay, cool.
I'm trying to answer this. This is a difficult situation. So sometimes patients would have, flushing and diarrhea and symptoms concerning for a neuroendocrine tumor. And despite our best efforts, we're unable to find a primary. In those circumstances, yeah, it is possible that there is, small pieces of neuroendocrine tumor in the intestine. Any tumor that makes carcinoid syndrome should secrete, serotonin products, metabolite products that you can detect in the urine. So on a 24-hour urine test, the 5-HIAA should be high. And that would be enough for me to confirm that you do have a tumor. If it's necessary to find it, you could do a laparoscopy, which is a camera evaluation where they look at the camera probes and they go little incisions and look around. But we have had patients who, have symptoms that are similar to carcinoid syndrome, but don't have it, don't have carcinoid disease that we can find. And what to do with that, that's a difficult scenario. It is difficult for everybody. And what to do, it really depends, again, on your discussion between you and your provider. Sometimes, even if you don't find a tumor, you'll feel better on the SSAs, and sometimes that's okay. You feel better on a medicine, that's great. So but again, that's a discussion between you and the doc and to figure out what to do.
Yep. All right. Thanks for your question. We just got a little shout out from Dr. Aman Chauhan. Hello to Dr. Hendifar and Rain from Lexington. One of the things I love about this show is a lot of the doctors in the community tend to join and tend to watch and contribute sometimes. I don't know if they're watching to learn or watching to study the other experts and see who's doing the best, size them up. But Dr. Chauhan, we got to get you back on the show, my friend. It's been a while. Thanks for jumping in and saying hello. Wendy says, and by the way, Wendy, who's definitely a friend of the foundation, is looking for a multidisciplinary team in Denver. If you, Dr. Hendifar, or anybody out there knows of that, chime in and help her. But her question is, I've had the Whipple and hysterectomy and liver resections, and I now know that I was wrong. She doesn't say why. I have a non-functioning pancreas, and I'm not diabetic. Any clue? That's the question. I'm not sure that follows it.
That's tough.
Yeah.
I'm sorry you've gone through big surgeries. Sometimes you do surgeries for neuroendocrine tumors and they kind of pop back, and then you kind of regret going through that exercise. It's tough, but I wouldn't necessarily say you did the wrong thing. You still got those tumors that you removed. They're now gone. I mean, that's one of the good things about surgery. I'm not a surgeon, and so, but I'll give them a shout out today. One of the good things about surgery is that whatever you remove is gone. It's not like medical treatments, which tend to keep it stable.
Good point.
So although it's kind of disconcerting for the tumors to come back after surgery, I think you still made some progress. You got to jump on the boat of getting, medicines on board to stop these cells from growing. Because sometimes even the best imaging we have, it is going to miss tumors. So even if we, with our own eyes, if we remove everything that we see, there are little cells that are in other places and those will grow. So if that's the situation that you're dealing with, then you got to get some other therapies on board to kind of control your cancer.
Yeah. I have kind of a broad question for you, but it's one that comes up a lot. I mean, you talked about giving a shout out to surgeons and that you're not a surgeon. And obviously each case of this disease is different, but sequencing, like in your typical, that doesn't even make sense, but your typical net is what I was going to say. But like what, where does that fall in your general approach? If you ask a surgeon, they're probably going to say first line of defense is surgery, right? Typically, some of them. But
Sure.
is there something that you prefer to try first? Do you think surgery is the first thing for most nets?
That's a great question. So I think it's really important when you discuss sequencing is that, because every case in neuroendocrine disease is so different that it really boils down to who's on your team.
Mm-hmm.
And, every team, it's like a basketball team or football. I mean, I'm a sports guy, but
yeah, me too.
so different teams have different players that are really good and different go-to people and different expertise. Do you know what I mean? So some places you're going to have people who are really good at certain things versus other places, so it might be, a treatment might be on the East Coast one way, on the West Coast another way, just because the expertise involved. And I'm not so sure. I know people are going to get mad at me. All Dr. Chuan might get mad at me, but I've never been a sequencing. I think sequencing is important in terms of, patient experience, patient quality of life, and matching that with the provider expertise. But I've never been a big belief that if you do a certain sequence one place, that that's necessarily the best sequence in another place, and that there's some things that are going to be studied in our community that are important that'll help us. Like, for example, whether or not CAPTEM versus PRT is better. But in my mind, I'm always like, well, if you do one, usually you can do the other next. So A to B versus B to A. So I try not to get too wrapped up into that. But what we've done at Cedars and in our local community is we have like just general guiding principles that we use to manage patients with neuroendocrine tumors. These are principles that it's kind of like our own little Bible, our own little 10 commandments that we've come across, that we've got and that we use and that we all agree upon for the most part. So it really helps out. And then, part of that is if a patient, now let's go back to the original question. So if a patient has disease that is able to be removed surgically, we usually tend to recommend that as long as the patient is fit, it makes sense, they have the right grade, and we have a litmus test. We like to get more than 90% out. So if you can't get more than 90% out, we get a little bit. And then we also have this general principle is that you don't really want to do too many of them.
Yeah.
Maybe one is probably good, maybe two, then we start to get a little bit more deliberate about it.
Yeah.
And of course, it's patient preference. If our patient says we don't want to do a surgery, then that's totally fine. We don't do it. So sequencing is tough, I think because, go ahead. I'm sorry to interrupt you.
No, I was just saying, indeed. Yeah. I mean, that's
it's
everyone.
tough because, in certain cancers, sequencing might make more of a difference because you're talking about decisions that are you don't have a lot of time in some other diseases. But for NETs, the amount of time we have to go from one treatment to another is quite long. So I just don't think A, B, C, CBA, BCA, BAC. I'm not so sure how much of a difference that can make.
It's a fair point. And also, to be fair, I don't think I've ever seen Dr. Chuan mad. I don't think he can get mad. So I think you're
I haven't either, actually.
You know what I mean?
Wouldn't want to see it.
No. It's a really good point. And I haven't heard anyone say it like that, or at least with the sports metaphor, which makes so much sense. Anybody can be a championship team. And if you're a smaller basketball team, well, then your strategy might be more fast paced, right? And you might be running the big guys up and down the court on the other team, but that either one of those teams could be an excellent, championship team.
Right.
So I really like that point. Depends on who you have on your squad in a lot of ways. I think that's a really, really fair point. So thanks for taking that question. It is one that it's a tough one, and it's, I wouldn't say controversial, but it's always in discussion and in debate. So thanks for taking the time. Moving back to the audience, Suzanne says, with regard to small bowel nets, oral targeted therapies seem to result mainly in stable disease, according to the literature I've seen. Have you had a different experience with your patients?
No, I would agree with that. I agree with what that is. Yeah. So with small bowel nets, right, the the treatments, the oral treatments are probably not as effective as they are in pancreatic NETs. That's a great point. And that always factors into our decision making. So our small bowel NETs get a lot less pills than the PNETs for that reason. Yeah.
Got it. And you said you have a lung net specialist on your multidisciplinary team,
Yeah.
right? Yeah.
Yeah.
So Rob has a
Or
question.
Dr. Pada, Suki Pada.
Okay.
She was at Stanford before.
Gotcha.
I got to connect you to.
Yeah, absolutely. One thing that I love, I mean, I've been working with CCF for 10 years, is that the amount of net specialists seems to have grown, tremendously in that time. Where back in the day we had the Wolans and the Warners and Walterings and,
Yeah.
but
They'll
now
be
it's like that community is really growing. That pool is really growing. Okay, so lung net question. Rob says, I had a net carcinoid in my right lung that was resected 2016. Results showed tumorlets in the lung. Is there any new research going on regarding lung nets? So that's really the takeaway. Like any new news, anything going on, any trials, anything like that you know about?
Yeah, I mean, there are, that's a great question. For lung neuroendocrine tumors, there's a couple of things going on. One, as you know, or maybe not, but there's well differentiated and poorly differentiated, okay? Now, the poorly differentiated are large and small cell. The well differentiated are typical and atypical. Right now, the typical atypical are being treated like the rest of the nets, and the large cell, small cell are being treated like small cell lung cancer, which is chemo and immune therapy. So immune therapy was recently approved for small cell lung cancer, which is huge. Also, lurbinectidine, which is a compound derived from a sea sponge, really neat chemical that was also approved. That might have applications to other poorly differentiated neuroendocrine tumors in other sites. So that's kind of the framework that we're using. As far as new ideas for the well-diff lung tumors, the real big focus right now is on whether PRRT can help those patients. So there's a big study happening soon that's looking at PRRT in well-diff lung tumors. Other than that, there aren't a lot of new medications for lung neuroendocrine tumors that I'm aware of. There are a lot of treatments being developed in early phase trials. There are bispecific antibodies, there are oncolytic virus therapies, there are all kinds of new things that are happening, but none of them that are far enough along where I can say to you, hey, this is something to look for.
Got it.
But I think the next thing for lung nets is going to be PRRT. We're going to be able to answer that question in a few years, get it on the label. I know it's been tough for our lung net tumor patients. I have several of them that are unable to get access to PRRT, even though most of the providers taking care of them think it's the right treatment for them. Our hearts go out to them. I didn't think this would be much of a problem, but I'm so glad that we have a cooperative group trial led by Dr. Hope looking at PRRT and lung tumors. I can't wait for those results to come out. Hopefully they're going to be, I believe they'll be positive, and then we can make sure that every lung net patient gets access to this great treatment.
Yeah. And Rob, we also have, I've mentioned a couple of times on the show that we have this video series or several videos over the decade, but a lot here in the past couple of years. And we actually did one on lung nets. And if you go to the videos tab, you can just cycle through the videos and you'll see that it featured Dr. Robert Ramirez, who's a lung net specialist. And at the time he was at NOLA Nets, which is a great program. He's moved on from there, but that whole video was
now?
Where'd he go? Nashville.
Oh, good for him.
Yeah, I mean, he was at NOLA Nets for a long time. That just happened very, very recently, actually, in the past couple of months. Okay, moving on. Folks, we have just about 15 minutes left. Great session today, but keep those questions coming. We're going to keep trying to answer them. From Thierry from France, hello and welcome. I have carcinoid cancer of the liver, and I'm looking for the best solution. Question with embolization. What happens to your tumor? Is it a big intervention? Thanks. Does that make sense? Some might have been lost in translation.
Embolization. Yeah. Okay. So it's a great question. Embolization is one of the treatments that is liver directed. So what makes liver directed therapy different than other therapies is that it's catheter based. The catheter goes into your groin. It tracks up your artery up into the liver, and then your arteries, they shoot contrast into the artery. the contrast goes, you can highlight the tumor locations, and then you can either embolize either bland, which is what a lot of places are doing now in the US, or chemo. And both of those have the same objective, which is to, disrupt the vasculature and kill the tumor. We're using a lot of bland embolization, although 10, 15 years ago, we did a lot of chemo embolization. It's one of those things where it's a pendulum that swings and goes back and forth and different ideas. The things to look for chemo and bland embolization, the principles are very similar. One thing, if you have a Whipple surgery, you can never do it. I'm just going to say that. Okay. So that's a general principle. You might have a case or two that you can get away with it, but highly don't recommend it. Your risk of infection will be incredibly high. So if you've had a surgery of your pancreas before, it sounds like you haven't, then don't do it. The other general principles are that, depending on your age and what else is going on, the big side effect of embolization can be post-embolization syndrome. So there are some symptoms associated with that. But other than that, it's a very effective therapy. And if it's recommended by your team, you should definitely go for it.
Got it. Awesome. Thanks, Thierry. Thanks for your question. Sarah says, Dr. Hendifar, could you give an assessment across the country? No specialist where I live. There is no such specialist where I live, and I would like a second opinion.
Sure. Yeah.
There you go. Easy.
You can call Cedars Sinai, and we do video appointments internationally. That's not a problem.
Awesome.
Happy to help.
Yeah, I mean, that's one of the things, from the pandemic that, has increased or worked to our benefits. Things like this show, things like telehealth that have become that won't be leaving, right? That have become more popular and that have actually opened up a lot of doors of opportunity for people. So there you go, Sarah. You got the green light. Hit him up. Okay, Dorina, who has been bringing the heat today with her questions, says, I keep hearing about how important it is to know whether there are Mets to the liver. Can you elaborate on why? Do liver metastases spread more quickly? Are there more symptoms associated with a NET if you have Mets to the liver? Is there a lack of treatment? Like, what is that? Why is that so important to know?
No, I think what Dorina's hearing is that it's one of the more common places that the tumors go. Mm-hmm. So that's why we're talking about it, because it just happens to be, and it has to do with the circulation in the abdomen, the portal circulation. It's interesting. I mean, the liver organ is an amazing organ, but basically it handles all the stuff that your body wants to get rid of as the blood flows through your abdomen up back to your heart. Everything goes to the liver. And that's just one of the more common places that metastases go. But other than that, there's no real significant meaning to them. But the other good thing about the liver too, though, it gives you the liver, if it spreads to the liver, it's a little bit easier to deal with than if it spreads to the bone, in the sense that bone lesions, you can't really remove them. And you can't really you can't get catheter-based therapy to them. So in some ways, liver lesions are easier to manage, and you get more people involved with liver. So that's why you're seeing more discussion about them.
Got it.
Lots of liver specialists. There's hepatologists, liver surgeons, there's all kinds of stuff. Interventionals.
For Wendy, who asked about MDT in Denver, you have a few people chiming in about Dr. Liu and his team. Definitely, Dr. Liu is awesome. And Marcia actually provided you with some information in terms of how to reach him. So hopefully that helps, Wendy. Thanks for being here, as you always are. Follow-up question, Dr. Hendifar, from Florian. Why do bright lung nets on the gallium-68 dotatate PET scan sometimes not appear, even though somatostatin receptors are present? In that case, is there another way to find out whether the receptors are present?
I didn't understand that. So okay. Is he saying that the tumors are not lighting up, but he knows they're low grade, or?
No, I think he's saying they don't appear on the scan. Why do sometimes bright lung nets on the gallium-68 scan sometimes not appear, even though somatostatin receptors are present?
Because bright usually means they're appearing. So, lung tumors, they often will not have somatostatin receptor expression. Mm-hmm. So if you have a lung tumor that's negative on the gallium scan, I don't think I'd be looking for reasons. I would just accept that. You could do a pathologic eval for somatostatin receptor, but that's not really what we use to base our therapeutic decisions on. Really use functional imaging, somatostatin scintigraphy, looking and comparing the uptake of the tumor compared to the liver and compared to the spleen. These are the criteria we use to decide treatment. So I know it's sometimes it happens commonly that lung tumors just don't light up, and it's frustrating. They're low grade. They act the same in every other way. They just don't light up. And I know it kills me too, because if they lit up, we'd have so many more therapies for these patients.
Yeah, that's a good point.
But I think that unfortunately, that's just how it is.
Got it. Hey, Florian, if I misrepresented your question, or if there's other
Let me know, Florian.
information that can provide a little more clarity, let me know. We still have just shy of 10 minutes. Karen hadn't heard much from you today. Karen says, would you say if the octreotide or lanreotide stops working and tumors are progressing, should you stop the shots or should you continue them?
Well, you guys are bringing the heat today.
They do, Dr. Hendifar. I told you.
Oh man. Yeah.
They don't
So
play.
I gotta say, there's no right or wrong answer. There's schools of thought, and I gotta say it's very regional. I mean, this is not really recognized in the endocrine tumor world, but there are different, schools of thought. I'm in the Wolin school of thought. We would typically continue SSA after progression, but there are other experts and providers who do just as good of a job who say that you don't. So I think that the one circumstance I will say that there's no question, if you have carcinoid syndrome, or if you have a tumor that's producing a hormone, you would continue the SSA. That everyone agrees on.
Okay. Any reason not to? Like any risks? I mean, besides just the annoyance of continuing to take shots, like.
No, I mean, I guess the risk would be just elevated blood sugar or continued exocrine pancreatic insufficiency. Outside of that, you're right. It's not, and that's one of the other reasons why patients typically continue them.
Yeah, that's
what
we
always have discussions with the patients and with the we kind of go through it and go through what we should do. Sometimes we decide to continue. Sometimes we do decide to stop. So really dependent on a lot of times patient drive that decision.
Yeah, that's a good point. Linda says, how is the decision made to use octreotide or lanreotide?
I guess that's provider dependent. There's no head-to-head comparison between the two. So most people look at it as Coke and Pepsi. There are some differences between the two. Sometimes if you have a patient or it's difficult to access the muscle, sometimes administration ease in your clinical setting could determine which one to use. But for the most part, I don't worry too much about it. Sometimes again, maybe our providers might say, oh, lanreotide might be easier than sandostatin LAR, and they want to use it. That's fine. Or sometimes there's a little bit of a difference in cost, but I think overall, it's really provider dependent, which one to use, and not much difference between them.
Gotcha. Folks, I see some of you chiming in about Dr. Ramirez. Yes, I wasn't very specific. Vanderbilt. I said Nashville, but Vanderbilt is where he landed. See, the community's tight here. We know where everybody moves.
I did hear that. I just haven't seen our colleagues in a while because of the pandemic. So
I know, right?
Have to catch up.
Bonita says, if treatment was successful, primary tumor in colon, small tumors in lung and liver, but there were new low-grade cells detected in the bones. They've developed into a new tumor in the CNS, upper spinal column. Is this a NET tumor, or could this be a NET tumor? And could you give any kind of insight into this case? I know that's a lot there, but it's for her mother. She lives in a different country. It's difficult for her to communicate with her doctor. So Bonita is just trying to get any kind of guidance here. And let me know if you want me to go back over the.
Could you go repeat that one more time?
Yeah. Primary tumor in colon, small tumors in lung and liver, but there were new low-grade cells detected in the bones, and they developed into a new tumor in the CNS, the upper spinal column. And she's like, is this a NET tumor? Like, I don't know.
Doesn't sound like it.
Okay.
It could be, if it is a NET tumor, it's going to be a high-grade NET from the sounds of it. Because typically well-differentiated NETs It can go to the bones, but not the spinal cord, not the CNS.
Mhm. And so for her mother, like any questions she should be asking, things she should be seeking out, steps she should be taking at this point?
Yeah, I mean, I think one thing I would do for high-grade neuroendocrine tumors of the large bowel, you probably want to make sure that you have molecular sequencing,
Mhm.
because those can detect variants that you can target with precision medicine. I think you want to make sure that she's seeing a radiation oncologist to be able to help with this CNS disease. And typically the treatment for a high grade or colon cancer is chemotherapy. So those are the kinds of things to be thinking about. I'm sorry to hear about your mom. It sounds like a tough situation.
Yeah, Bonita, sending love to you both. Dr. Hendifar, what, if anything, well, I'm sure there's lots of things, what would you like to see? What would help you do your job better? Like thinking about next 5 years, treatments, things, tools in your toolbox that may be coming down the pipeline. Is there anything that you're particularly excited about, or you're like, oh
Yeah,
man,
I'm super. I'll tell you what I'm excited about.
let's
I'm
go.
super excited that when I was first starting under Dr. Wolin, I'd always be like, Dr. Wolin, what should we do, right? Because it was before it was like mentor, mentee, and it was information was handed down. Now we're kind of agreeing across the board on what to do, and the field is becoming a real science. It's becoming a real established approach to treatments. Our patients know what to do now. It's incredible. Whereas
Yeah.
before, no, you could finding expertise was so difficult. Now look, we have millions of nodes of expertise from patients to providers. That's going to continue to happen. And what I'm really excited about is that, and I think in a few years, if you're a net patient in LA or you're a net patient in New York or in Iowa or Vanderbilt or NOLA, you're going to get the same treatment, the same approaches, the same understanding, the same information. And it's going to be like one of the more common tumors like breast or lung or colon. Everything is going to be kind of everything's on the table. Everybody knows what to do, and everything is good. It's not going to be a situation where like, well, oh no, we didn't do this, we didn't do that. Let's scurry up and catch up. Let's do this and let's do that. So I think the care in general is going to improve a lot, and definitely it's part of that is a big part of that is thanks to the Carcinoid Cancer Foundation, this podcast, the information that the patients have. A lot of times they're transmitting the information, this important information around the country, and it's just going to get better, and we're going to do better as time goes on.
That's good to hear. I am hopeful as well. Folks, if you got a lot of value out of today's program, I want you to look at the bottom of your video screen and just smash that heart emoji and let us know that you got a lot of value and we answered some of your questions today. I will say that Karen says, and this is in reference to you, Dr. Hendifar, he says we are bringing the heat. Most likely it's because he is very good. Good one, Rain. I didn't select him, but I enjoy him. He has done a good job. I'm Dr. Hendifar. You can't see him, but the heart emojis are flooding in right now, my friend. Appreciate your time. Thanks for joining us, man. This was really a pleasure, and I appreciate you making some time for us.
Oh man, thanks for having me. Special congrats to you and your family for the newborn.
Thanks, brother. Appreciate that, man. Yeah, send help, please. Send help. Thanks to you all at home, as always, for joining us, and we hope this program helped answer some of your questions. Again, reach out to ccf@carcinoid.org or here on the Facebook page. You can send them a direct message for any further information, follow-up questions, anything that you have. We're here for you. Always. Thanks again to our presenting sponsor, Cedar Therapeutics. Could not do this program without them. And finally, my name is Rain Bennett. Thank you for watching. I have been your host. And please join us next week on Luncheon with the Experts. Stay healthy, stay safe, everybody.